Hello, everybody. My name is Jens Juul Holst. I'm from Copenhagen, from the University of Copenhagen, and I was asked to discuss the incretins in the gut-brain-pancreas axis, a new paradigm in metabolic regulation. So let's get started. Here, I'm showing you what the incretin effect really is, and what it is the amplification of insulin secretion, which is observed when glucose is taken in orally rather than intravenously. So in spite of having the same glucose concentration, much more insulin is released when the glucose is taken in orally. And the interesting thing is how this happens, and we think it's due to the incretin hormone secretion. And we have two hormones, the GIP, the old incretin, and GLP-1, a new incretin. And let's see about that. So here's a list of the gastrointestinal peptides, and you can see it's a huge list. And it's depicted here as a function of the year of discovery. And if we go back in time to around the 1970 period, then there was one peptide that came out, and that's the glucose-dependent insulinotropic polypeptide, GIP. And if you look at it here, this is how it was isolated as an inhibitor of gastric acid secretion in dogs here, and you can see the inhibition of acid secretion. But it was soon, and that was the interest in those days, but it was soon found out that it also stimulated insulin secretion. And here you can see the stimulation of insulin secretion while it's given intravenously, in spite of the fact that glucose levels are actually lower. But there were several reasons why GIP could not be the only incretin hormone. So GIP immunoneutralization could not remove all the incretin activity. We found that patients with intestinal resections, there the incretin effect did not correlate with GIP, but with the lengths of distal small intestine remaining, suggesting that something came out of the distal small intestine. And it was also found that porcine incretin was, that porcine GIP was inactive in type 2 diabetes patients. And that we can see here, where porcine GIP was infused to people in normal subjects, and it had a wonderful effect on insulin secretion, and also in type 2 diabetic individuals and type 1s, where it was barely without any effect at all. So there were plenty of reasons to look for other things. So what we did was to look at reactive hypoglycemia in individuals after operations on the GI tract. And here you can see people that had reactive hypoglycemia after operations. And this was clearly due to increased insulin secretion. So one could think that this was perhaps an action of incretin hormones. There were various reasons to believe that it could not be GIP. So we were looking at something else. And here, what we were looking at are cells in the small intestine that stain with antibodies against glucagon. And so could they be possibly the responsible cells? And you can see here that if you inject glucagon to people, you will have a strong stimulation of insulin secretion. So this might be the explanation. It took about 10 years to find out what was the explanation. And the explanation was this peptide here that you see the structure of it. It's glycentin. And glycentin was found in these cells in the gut. And as you can see, it has glucagon in the middle, and that explained the reaction with the antibodies, of course. But apart from that, it was a 69 amino acid. But it was interesting that it had these glucagon sequence in the middle. It didn't work on insulin secretion, we found out later. But it was interesting, of course, because we suggested that it might be pro-glucagon, the precursor of glucagon, which was very interesting in those days. But there were things indicating that pro-glucagon had to be larger than glycentin. And there were fragments that did not contain glucagon at all. So what was in the rest of pro-glucagon? And this is what was found out here, where we see this study by Graham Bell, where he looked at the pre-pro-glucagon sequence from hamsters by molecular biology techniques. So this came out as the cDNA sequence, of course, and it confirmed completely that half of pro-glucagon was occupied by glycentin, with glucagon in the middle here. But then there was, in addition, two additional GLP glucagon-like peptides in pro-glucagon, GLP-1 and GLP-2. And this was exactly the information we needed. So we immediately synthesized these peptides and made radioimmunoassays for both GLP-1 and GLP-2 and started looking for them. And what we found was that there was a differential processing of proglucagon. So here we have proglucagon again. And we found that what happens in the pancreas is that glucagon was cleaved out of this big proglucagon form. And this sequence was then a single large peptide that contained both the GLP-1 and the GLP-2 sequences. But, you know, if this has been the story, we would never have heard about GLP-1 because it would have been in this inactive peptide. But in the gut, something different happened. So here in the gut, this part of the precursor remained together as glycentin and sometimes oxyntomodulin. We'll come back to that. And then in addition, GLP-1 and GLP-2 were cleaved out. And now, of course, it became interesting to find out what they did. So what we did was to isolate and purify peptides with GLP-1 immunoreactivity and using sequential chromatography. And we had them sequenced and could then test their effect on the porcine pancreas. And here is the porcine pancreas we were using for this. And what we found was that the GLP-1 we could extract was exactly very, very strongly stimulating insulin secretion in this preparation. So indeed, we had been able to dig out an insulin-releasing peptide. And this was really interesting because, as you can see here, it was only active on insulin secretion when the glucose was either normal. This is again studies in the isolated perfused porcine pancreas, or slightly elevated or very elevated. And you can see that the response was completely dependent on the glucose in the perfusate, or plasma if you want. Whereas if it was low, there was no effect. So you could possibly create hypoglycemia with this peptide. That would be the conclusion. But on the other hand, it also did something else, which was really, really interesting. And it also inhibited glucagon secretion, as you can see here. And this was new and completely unexpected. So with this, it has two mechanisms of action. And you can see here what happens if glucose rises because you eat, for instance. And that means that the pancreas will then release insulin, which will make the liver take up glucose and the tissues take up glucose and bring back glucose levels. And if you have a fasting with glucose falling, then you have the pancreas releasing glucagon that will then stimulate the liver to create glucose, and you will bring back the homeostasis again. So by inhibiting or by influencing these two mechanisms, you would have a double mechanism acting on the blood glucose. And that's exactly what happens, as we could show later here, where you can see GLP-1 being infused to people in absolutely physiological levels. And what you can see is that glucagon is inhibited, insulin is stimulated, and then the production in the liver of glucose is inhibited by about 30%, as you can see here. As a consequence of that, glucose starts to fall, as shown here, but it doesn't fall very much, only at the most about 1 millimoles per liter. And then the effect stops because of the glucose dependency of the action of GLP-1 on insulin secretion. That's another way of demonstrating very clearly the actions of these two incretin hormones, and that is to use receptor antagonists. And for GLP-1, we have known for a long time a very efficient and selective inhibitor of the GLP-1 receptor, exendin 9. And we managed to isolate and prepare an antagonist of the GIP receptor in 2017 and do a lot of studies with these. And here is the GIP receptor antagonist. You can see that it's very potent in its inhibition of binding. It doesn't have any own activity. And it really, if you compare it with GIP, it's a very potent antagonist. And you can see from the shield plot here that it's a competitive antagonist. So then what we could do then was to look at what happens to glucose tolerance if you inhibit the GIP receptor, and we could do that with the new antagonist, or the GLP-1 receptor. We could do that with the old antagonist, exendin 9, or the combination of the two. And what you can see is that the control experiment is here, and then with either of the two antagonists, you would impair glucose tolerance. And if you inhibited both the GLP-1 and the GIP receptor, you would actually have glucose intolerance. So that demonstrates to you that both of the peptides are very important stimulators of insulin secretion, and that both of them are important for glucose tolerance. And we could look at the effects of the two by comparing directly the effects of their insulin secretion, and that could be done as shown here. And we were able to then map the importance of the two hormones at the concentrations where we find them in the body. And we found that GIP responsible for almost half of the insulin, the incretin action. Glucose alone will stimulate insulin secretion by 25% or so, and GLP-1 will then be responsible for the rest. So GIP is indeed, in healthy individuals, a powerful stimulator of insulin secretion. So GLP-1 is an incretin hormone. What else can it do? Well, it can also inhibit gastric emptying, as we showed here for the first time in 1993, very powerful inhibitor of gastric emptying rates. It can also inhibit acid secretion, and this is one of the things we originally looked at. So here you can see the very profound inhibition of acid secretion with GLP-1, and particularly combined with the other peptide that is released from the gut, PYY. It's a very powerful inhibition of acid secretion. But then it was time to look at another effect of the gut hormones, that of appetite and food intake. And that's what we did here. And you can see if we infused people with physiological concentrations of GLP-1, you would increase satiety between meals and you would decrease hunger between meals. And as a result of that, you could also inhibit appetite and food intake. And here is the food intake to an ad libitum meal after infusion of GLP-1 with a significant inhibition of food intake. And this is an important slide because it shows you that from a number of studies that were then performed, you could tell that the inhibition of food intake here was proportional to the rate of infusion of GLP-1. So the more GLP-1 you would infuse, the more you would inhibit food intake. Let's keep that in mind. How does it do it? And one of the ways it could be an effect of the stomach. That's a small effect, if any. It could be an effect on sensory vagal afferents. That is true for the endogenous peptide. But infused GLP-1 has its way directly to the brain to the CNS via the circumventricular organs. And it looks like this. This is the area postrema. And here we are looking at where does GLP-1 go. This was radioactively labeled GLP-1, so we are doing autoradiography here. And it goes directly to the area postrema and to the subfornical organ. And here you can see that in these organs, I mean, particularly in area postrema, it also excites the neurons because this shows C-FOS after GLP-1 administration. So that is activation of the neurons compared to the control experiment here in the area postrema and also in the nucleus of the solitary tract. So, and it also interacts or activates nuclei, the central amygdala, and also in the paraventricular nucleus and the arcuate nucleus. All of these are important regions in the brain, important for appetite regulation and for reward. And here you can see where semaglutide, the very famous drug, goes. To the left, you can see where it enters the brain, exactly at the circumventricular organs. And here you can see where it activates. So let me show you that if I can. Here we go again. And here you see to the right, the activation of neurons. That is C-FOS. And you can see it's in the amygdala, the parabrachial nucleus, the nucleus of the solitary tract, and the hypothalamus, exactly as I described for you. So this is what happens. All of this, of course, meant that it was an extremely interesting peptide and that it also affected beta cell function and could perhaps even work on reduced beta cell mass, as we have in type 2 diabetes. It could inhibit the glucagon secretion that we have in the increased one that we have in type 2 diabetic individuals. It could inhibit overeating and obesity. We'll come back to the complications, the cardiovascular complications, and it could even inhibit insulin resistance. And it was time now to look at people with diabetes. And here we were able to show that a 4-hour infusion of GLP-1 could completely normalize the glucose concentrations of individuals with severe type 2 diabetes. And this was because of an stimulated insulin secretion and an inhibited glucagon secretion, as shown here. So all in all, this was really what we called at that time the diabetologist's dream. Indeed, Meta Sandler here was able to look at a continuous infusion of GLP-1 for 6 weeks using insulin pumps. And what she found in those 6 weeks was a tremendous improvement of glucose values, reductions of A1C in 6 weeks, and weight loss of 2 kilograms, improved insulin sensitivity, enhanced beta cell secretion, and there was no side effects in this study at all. So the time was ready to start treating. But now let's shift gears for a while. What is the most efficacious treatment of obesity and diabetes that we know? Well, it is actually bariatric surgery. And I'll show you why. Why are these operations so effective and what can we learn from that? That's what I want to discuss right now, because then we know something about where we should be going. So here we have the weight loss after gastric bypass, the famous SOS study. Here, people were looked at for 20 years, and you can see that there is a very major weight loss which is maintained for 20 years after gastric bypass operations. And here is an example. Here we have one of our patients, 53 years, type 2 diabetes, hypertension, dyslipidemia. He had a BMI of 55, fasting plasma glucose of 11, and he was on metformin therapy. And then he had his operation. And 1 week after, his BMI was almost the same, but he still had now a glucose concentration of 6.5 millimolar and no diabetes mechanism. So that's what made Walter Porteous to write this wonderful paper back in 1995, where he said, who would have thought it that the gastric bypass was the most effective therapy for adult onset diabetes mellitus? So what I want to emphasize here is that what happens as a consequence of these operations and this very great improvement of body weight and diabetes. First of all, you can see to the left here that the microvascular complications over this 20-year follow-up period are greatly improved. And also the macrovascular complications are reduced by about 30% here. And here you can see that mortality, even mortality, is hugely decreased by the operation, by 30% here at the 16-year, and over here in a Swedish study, more than 50% reduction of mortality rates. Indeed, if you look at it here in a large number of people that have been operated with gastric bypass, 174,000 individuals here, those that had diabetes at the time of operation, they can expect an increase in their median life expectancy by 9.3 years, which is really sensational. Those without diabetes could increase their life expectancy by 5 years, and that's because they, of course, have less problems to deal with than the diabetic individuals. So what's the mechanism here? First of all, we have, after the operation, calorie restriction that causes hepatic insulin sensitivity to return to normal. You have an unretarded passage of nutrients down to the small intestine here. That's where you have a secretion of GLP-1 and PYY, and the GLP-1 then acts on the pancreas. And you can see here the level of GLP-1 secretion, which is hugely increased, up to 30-fold increased compared to before operation, both in people with diabetes and in normal glycemic controls. And if you look at glucose tolerance, here we are looking at people with diabetes. They had diabetes before the operation, as you can see. 1 week after, the glucose tolerance is much improved, and after 3 months, it's really normal. And we can look at that after we can block the GLP-1 receptor. And we have this blocker that I already mentioned, Exendin 9. So if you do that and take away the actions of GLP-1, you can see that glucose tolerance is impaired before the operation and also very much impaired after the operation. And if you look at the result here after Exendin 9, it is actually completely back to where we were before the operation. That means that all of that was gained on glucose tolerance was lost when we take away GLP-1 action. And the same is true for insulin secretion, of course. Here you see insulin secretion before the operation, typical type 2 pattern, and then the left shift and the increase after the operation at 1 week and 3 months. And again, you can block the actions of GLP-1 by the Exendin 9. And you can see that you can impair insulin secretion before, but certainly after the operation. And again, if you look at the result after the operation, 3 months here, we are back to exactly where it came from before the operation if we take away GLP-1 action. So here is an example of the bypass, the reactive hypoglycemia after this operation. And you can see here there are individuals that have reactive hypoglycemia after the operations. But if you give them Exendin 9, block the GLP-1 actions, the hypoglycemia goes away. And the same is, of course, the insulin is completely normalized. So this is, I think, is the strongest indication of the importance of the GLP-1 for the glucose control after these operations. What about the weight loss? Again, we have that the food is entering the small intestine, and we have this tremendous release of GLP-1 and the other peptide, which is called PYY. And so we did some experiments to find out what the consequence of GLP-1 and PYY would be. And you can see that here is the experiment where we infuse PYY and GLP-1 to the concentrations we see in the patients. And here we can see what happens here with GLP-1 and PYY. On energy intake, that's a small decrease in energy intake with GLP-1 and PYY. But together, there's a very powerful inhibition of energy intake with the two hormones. So now we can map what happens if we can block the GLP-1 action, and we can do that with Exendin 9, as I suggested. For PYY, we didn't have any antagonist, but we have something else. PYY is secreted as a 1 to 36 peptide. It's inactive in terms of inhibition of food intake, and it's converted to PYY 3 to 36 by this enzyme, DPP4, that also inactivates the GLP-1. And we can block that enzyme with a DPP4 inhibitor, sitagliptin here. Here, now it's blocked. And now there's no active PYY. And if we do that, then we can study the effects of meal tests. Here we have it, a standard meal test, and we can do that without GLP-1, without PYY, and without both of the two hormones. And if we do that, we see that the food intake is not significantly affected with Exendin because of the other hormone, not significantly affected with DPP4 inhibitors because of the other hormone. But if we block both of them, then we have a 20% increase in food intake, suggesting that this was the effect of the two hormones. So what we have learned for all of this is that after this operation, we have an altered secretion of GLP-1 and the other hormones, and that elicits anorexigenic effects and insulinotropic effects. So effects on the on insulin secretion and on satiety, and that leads to calorie restriction and weight loss. We also have decreased postprandial glucose and improved glycemic control. And we, in addition, because of the increasing weight loss, will have an early increase in hepatic insulin sensitivity, as shown here to the right, and also in whole body insulin sensitivity, which is improved later than the hepatic insulin, but according to the weight loss, and very strongly later. So now the question is, can pharmaceutical applications of GLP-1 and the other gastropancreatic hormones substitute the great effects of bariatric surgery? And that's what we will look at in the next talk. Thank you very much for this. Stop. Welcome again, everybody. Let us get on with the second talk about the incretin revolution from GLP-1 to dual and multi-agonists. So we have described all of the actions of GLP-1, and we have seen that there is a potential by the gut hormones to almost completely restore weight to normal levels, and also to eliminate diabetes. So let's see if this is possible with the gut hormones. Now, with GLP-1, there is a problem, and that is that native GLP-1 is rapidly degraded by this enzyme DPP4 that causes a half-life for the peptide in the body of 1 to 2 minutes, and it cleaves here, and this remaining part here is inactive. And there's one more problem, and that is that the kidneys also remove the peptide with a very high clearance rate, so that the half-life of the peptide, because of that, is only 4 to 5 minutes. So these are formidable problems, of course, and they needed to be solved, both of them, for a usable GLP-1 agonist to be made. And here we have the structure of the available GLP-1 receptor agonists, the ones that really are important on the market today. And the most important, so there are a group of short-acting ones, and we will not talk more about those because they're irrelevant these days. The most important ones are the long-acting ones, semaglutide here, which is the GLP-1 sequence really with a fatty acid associated to it, and that gives it a long half-life in the circulation, a half-life of 1 week. Here's another one from Eli Lilly. It's called dulaglutide. It has a large molecule attached to it. It's also weakly, but it's not as powerful as this one down here, which is called tirzepatide. And it's a combination of the sequences of GIP and GLP-1. Its half-life is also 1 week, and that's again because of a fatty acid that is attached to the molecule here. And let's see how good it is. So here is one of the registration studies for tirzepatide, the SURPASS-2 study, where people with type 2 diabetes were looked at, large number, several thousand, were looked at over 40 weeks of therapy. And here we see the A1C levels, the glucose regulation, and you can see that more than 50% at this dose of tirzepatide, more than 50% reached an A1C level of less than 5.7%. And 5.7%, as you know, is normal. So that really means that in half of these individuals, there was almost a complete remission, although with a drug, of course, of their diabetes. There was also a tremendous improvement in body weight of 12.4%, as you can see here. It was compared to semaglutide, and it was not nearly as good as semaglutide. But again, as we will come back to, the doses are, of course, also hugely different. This was 1 milligram, and this was 15 milligrams. So there's quite a difference in dose, which is often forgotten. Well, let's have some more sensational results. So the effect on diabetes was sensational, and the effect on body weight was also. But what about the cardiovascular complications of diabetes? And here we have one of the first really promising studies. This is the SUSTAIN-6 trial of semaglutide, where you can see that over 2 years, there was a reduction of the risk of getting a cardiovascular complication of MACE, major adverse cardiovascular events, by no less than 26%. And of course, this has been looked at in all of the studies that have been done, all of the cardiovascular endpoint studies, the cardiovascular outcome studies, as it's called these days, with all the different compounds. So you can see here that all of them are nicely to the left of the unity line here in this forest plot, which means that they all favor, they are better than controls in terms of protecting against cardiovascular complications, except for two, those that are based on exenatide. And that is a bit strange, but is nevertheless the case. Overall, there's a very significant improvement by 20% of these compounds in all the controlled trials. And not only do we have this effect on MACE, but actually we also are beginning to see that both semaglutide and tirzepatide are active on heart failure. And here you can see the overall improvement in heart failure rates from these plots here. And over here you can see that this is distributed into those with the rejection, with the reduced ejection fraction here, very good effect, and those with preserved ejection fraction. And there was a very good effect on those, both of them. So both types of heart failure are beneficially affected. And the same is true for tirzepatide, as I indicated. Here, there's a very nice reduction by 38% in the rate of heart failure of HFpEF in this case, preserved ejection fraction, which is the most common in people with diabetes. Very nice effects of tirzepatide. Here's another study with semaglutide. One of the components of the MACE is stroke. And here is the combined findings in people with type 2 diabetes in SUSTAIN-6 and PIONEER-6 trials. You can see that there's a very nice reduction in the rate and risk of developing stroke over these 2 years. And here we're looking at the risk of dementia in studies here where people that are treated with GLP-1 agonists or DPP-4 inhibitors or sulfonylureas are compared, and you can see the great improvement with GLP-1 agonists when we compare the two. Here's another study where the GLP-1s are looked at in combination or in contrast to SGLT2 inhibitors. And in this study, which is based on 26 controlled trials and 160,000 individuals here, 10 of the studies were with GLP-1 receptor agonists, 12 with SGLT2 inhibitors. And here you can see the risk in dementia, which is reduced by GLP-1 agonists by as much as 45%. But actually not affected significantly by the SGLT2 inhibitors. And again, very interesting, the risk of developing Alzheimer's disease in people with type 2 diabetes. And this is a huge study and millions of thousands, hundreds of thousands of individuals where there was a reduction by 40 to 70% for the risk of first-time Alzheimer's disease diagnosis with GLP-1 receptor agonists. And one more fantastic thing. This is a study of GLP-1 and GIP receptor agonists, and that of course covers tirzepatide and semaglutide on people with opioid and alcohol use disorders. And again, we're looking at a very large number of patients, very large numbers indeed. And what we can see is that there's a risk of cases of opioid overdose by 40% with the GLP-1s here, and also of alcohol intoxication by 50% here. So it's really a very strong effect, which is probably a consequence of the effects on the reward system, as we discussed briefly. Here is a very important trial, the FLOW trial in people with type 2 diabetes and chronic kidney disease, where semaglutide demonstrated a 24% reduction in the kidney disease-related events here. So the combined primary endpoint included 5 components measuring progression of chronic kidney disease, risk of kidney disease, and cardiovascular mortality. And as I said, it was reduced by 24%. And here are some of the data, and I'd like to emphasize that one particular set. So these are all the cardiovascular and renal endpoints, of course, that are improved in the study. But over here, we see the glomerular filtration rate, which is, of course, a direct measure of kidney function. And you can see here that if you treat with semaglutide, the decline in glomerular filtration rate in kidney function, which is seen in these individuals with the kidney problems, is slowed down when you give semaglutide. So you can keep the kidneys healthy for a longer time with semaglutide. So how does it do all of this? And of course, there are a number of important things to look at. There are effects on the blood vessels. There are effects on inflammation, which is really very important, I'm sure. And then there is, of course, the effect of the body weight reduction by itself. And here you see the effect on body weight in the step 4 trial of semaglutide, 2.4 milligram, the Wegovy. And you can see that there is a reduction in the study, 1 of 4, during 68 weeks of about 18% in body weight. And that has been looked at also in a cardiovascular outcome trial. The major effect here, it's called SELECT trial. And there was a reduction in cardiovascular events by 20% in adults with overweight and obesity, but no diabetes. And I think this is very, very important that you can improve the cardiovascular risk in people with obesity in this way. Tirzepatide, of course, is also looked at, and here's a registration study. This is the SURMOUNT-4 trial, and here there's an even greater effect on body weight, 26% here. Again, it's the high dose, 15 milligrams here. So you have a very pronounced effect on body weight here. So that is nice, but there's even more importance to this because the SURMOUNT-1 trial was extended by another 2 years. So we have an observation period of 76 weeks. And here they were looking at the occurrence of new diabetes in this study. So, and that risk of developing type 2 diabetes was reduced by 94% in these individuals with obesity or overweight. And that tells you that you can even prevent the diabetes from happening when you treat with a GLP-1 receptor agonist in these individuals. You also had, of course, a major weight loss. There are more effects of the GLP-1 agonists. Here, tirzepatide on sleep apnea, and you can see that there is a very nice effect on sleep apnea in these studies, and of course of weight loss. And that has been approved now, this drug, for the treatment of obstructive sleep apnea. Here is steatohepatitis, which is common for both of the compounds. Tirzepatide here, looking at steatohepatitis with liver fibrosis, and you can see the greatly improved rate here, treatment effect with tirzepatide compared to placebo in the study. And we also have the obesity-dependent cancers. So here is a study where 13 of the obesity-associated cancers were looked at. This is 1.6 million patients where some had been treated with GLP-1 receptor agonists. And you can see that in those that were treated, there was a reduced occurrence of these cancers, a very significant reduction in the rate of these cancers. Here is, for example, shown colorectal cancer and liver cancer. And so this, again, is an effect, probably, of course, by reducing the weight, since they are weight-dependent cancers. So this is what we can expect of the GLP-1s. So what is on the agenda now in the horizon? What new compounds do we have? And of course, there is GLP-1, and is it now, is the dose of semaglutide appropriate? So in one of these studies, we're looking at a higher dose. We will also be looking at oral GLP-1. As I said, tirzepatide is a combination of GLP-1 and GIP, and there are a number of other GIP agonists in development. There are also, and this is very confusing, but nevertheless true, a GLP-1 plus GIP antagonism, which is being evaluated. And there's a compound here from Amgen that we will look at. It's called Maritide these days. And there's another one here from the company Antag. Over here, we have another combination that's with amylin agonists. We'll have a look at that. And we have, of course, glucagon agonism, which is combined with a number of compounds, and we will look at that also. PYY is the logical choice, but there isn't a lot of data here. And then, of course, the combination of GLP-1 with glucagon agonists, as indicated here. So let's have a look at it. So this is the 77.2 milligram of semaglutide in people with obesity. And here we're looking at the results here, and you can see that now we're having effects of up to 20.7% of weight loss with the increased dose of semaglutide, suggesting that also semaglutide can have dose-dependent effects. Let's have a look at the combination of GLP-1 and amylin agonists here, and here we have them. The new ones so one is cagrilintide, which is a fixed combination of cagrilintide, an amylin agonist, and semaglutide. And why would one do that? That is because we have in the combination a reduced appetite and food intake and increased satiety, and we should have an even further improvement of insulin sensitivity, a further decrease in glucagon secretion, and a further emptying of gastric emptying. So all in all, an improved effect on both obesity and diabetes with a combination of those two. And that is what has been seen. And here's some very recent results here with cagrilintide alone and semaglutide. And you can see that there's a nice effect on body weight of both these compounds. But together, in a combination, there was an effect on body weight of 22.7% in this REDEFINE 1 study. It's also been looked at in people with type 2 diabetes. And here again, you can see the reduction in weight here. And it's up to almost 16% weight loss here, which is really quite a lot. And here you can see the effects on A1C, which is also almost 2% here, which is also a very strong effect. So that combination is very potent. They have also developed amycretin, which is a unimolecular GLP-1 and amylin receptor agonist. And there are some phase 2 studies that were released here very, very recently. And you can see the weight loss here over 36 weeks, which is coming down to 20% or more. And here are some other doses here where you can see the weight loss. Very strong effects still falling at 36 weeks. So this suggests that the amycretin is very powerful in terms of weight loss. Here's another thing we are looking at. So if you remember what we said about proglucagon and its cleavage pattern, glycine may be cleaved to oxyntomodulin also. Oxyntomodulin is interesting because it has effect on both the GLP-1 and the glucagon receptor. And here you can see its interaction. But then it has been possible, so it acts on both receptors, both the glucagon and the GLP-1 receptor. So now it's been possible to synthesize compounds that are acting on the Juul, the two receptor agonists, and that have a long half-life. And here's one example. And there were two that were published in 2009. And that has led to a large number of studies of various combinations of GLP-1 and glucagon, mimicking the actions of oxyntomodulin. Here's pemvidutide, survodutide, mazdutide, efinopegdutide, this one, and retatrutide. I'll come back to that. So here we're looking at weight results with these combined. And this is in people with diabetes. The red figure, 13, is in non-diabetic individuals. And you can see that there are pretty strong effects on body weight of all the compounds. This one is sensational, and we'll come back to that in a minute. They've also been studied in people with diabetes, as the red figures indicate. And in some studies, there's a nice effect on reduction of hemoglobin A1C in spite of the inclusion of the glucagon part, as indicated here. But the most important is that they cause a reduction in liver fat. And that's, of course, an action of glucagon in this combination. So it's quite strong. It really is they are very, very effective in removing the steatosis in patients with MASH, as we know it to call it today. All cause gastrointestinal side effects and increases in heart rate, I must say. So here's retatrutide, which is a GLP-1 glucagon co-agonist, but it's also a GIP co-agonist. So it's a triple agonist, and a single molecule that included all of these components. It was prolonged, so it's weekly with a C20 fatty acid here. It's very potent on the GIP receptor. And so let's see. Here we have some results. This is in type 2 diabetes in diabetic individuals, and you can see very strong effects on hemoglobin A1C, as indicated here, in spite of the inclusion of glucagon, I must say. And here we see the weight losses, and this is over 48 weeks, and you can see that there is an almost 25% weight, and it's still falling in these type 2 phase 2 results. Let me show you this result, which is as I indicated, there was also a GIP antagonist out there, which has been combined with a GLP-1 agonism in a single molecule. And you can see here that also this called maritide molecule very strongly inhibits food intake and weight loss here. Here is a 1-year result here that you can see here. And there is also a nice effect on A1C in the controls, but certainly also in the people with diabetes, a very strong effect by 2%, and also very good effects of 70% in people with diabetes on body weight in this study. So these are phase 2 studies, and the phase 3 is now ongoing, and it will be very exciting to see how it fares in the phase 3 study. But it just illustrates that there are things we don't really understand. That is how GIP agonism plus a GIP antagonism can both lead to increased weight loss when combined with a GLP-1 agonist. Oral. So we have discussed the 7.2 already, but now we should look at oral administration of these compounds, because that, of course, is very important. And here we have semaglutide, which is available with a combination of what is called SNAC. It is packed in a tablet that adheres to the gastric mucosa and then buffers the pH and allows the GLP-1 to remain intact and to diffuse across the epithelium and into the blood circulation. And once it's in the blood circulation, it behaves exactly like semaglutide that has been injected. And this is what is shown here. The efficacy, whether it's by 1 milligram subcutaneous or 14 milligrams of oral semaglutide are exactly the same for the same exposure. This graph here shows the exposure rates in the different studies, and the same is true for the body weight. Exactly the same, whether it's oral or whether it's subcutaneous. And the same is true for the side effects, the nausea and the vomiting, which is a small risk, of course, in these studies. So they work the same. And the key outcomes of these global trials, the pioneer trials with oral semaglutide here are shown here, and all these dark columns here show the superiority of semaglutide compared to conventional therapies with empagliflozin or sitagliptin or liraglutide and insulin. Here's another trial where they are looking at 25 milligrams and 50 milligrams because it was felt that more could be obtained compared to the 14 milligrams that have already been approved. So here we have the design of the study, and let us jump to the results here. Oral semaglutide at 25 milligrams in adults with overweight or obesity. So we have here a nice effect of 14% of oral with oral GLP-1 here, like over 64 weeks. And of course, there's a cardiovascular outcome trial that has been carried out also with the oral semaglutide. And this time it's 14 milligram dose, the approved dose. And these have been looked at for up to 5 years until the sufficient number of events were collected. And the result is that in these 10,000 individuals followed up for about 48 months, the hazard ratio was decreasing by 14%, as you can see here, very significant. And even the serious adverse events were lower in the oral semaglutide compared to the placebo group. And the gastrointestinal problems were very similar in the two groups. There's another very important oral GLP-1 receptor agonist out there. That is orforglipron, which is a small molecule this time. It's not one of the GLP-1s at all, but it interacts with the GLP-1 receptor and can be given orally as a small molecule. And here we have the results, some of the shots, the phase 3 results that have just been released here. And we have the 3 doses of orforglipron, and you can see the weight loss here in this study after 72 weeks is about 13% here weight loss with the high dose. And here we have hemoglobin A1C levels, and you can see that the very nice reduction in these different doses here compared to placebo in this study of patients with type 2 diabetes. So 2 very promising compounds, orally available compounds available. And this is the weight loss in the people with diabetes, 8% this time, perhaps not as much as the other one, but still a nice weight loss. Here is a very interesting study where people from the Veterans Administration were looking at the huge databases they have, where they were able to look at 250,000 cases of people treated with GLP-1 receptor agonists and very large numbers of other treatments here. And then they were able to control this group with this huge group, either with the group of treated individuals or with the non-GLP-1 group as a total. And what they found was that significant reductions were in substance use, psychotic disorders, seizures, neurocognitive disorders, Alzheimer, dementia, coagulation disorders, infectious illnesses, and several respiratory conditions. So these are all the beneficial actions that one could obtain in addition to, of course, the effects that we have discussed already. Problems were the gastrointestinal disorders that have always been there, the nausea and the vomiting, but it is in a very limited number of individuals. Hypotension came out because there is an effect on blood pressure, which is usually considered beneficial, but in very few people, it can be a problem. Syncopes were seen in a few cases. Arthritic disorders were also observed, and this needs to be looked at because otherwise it has been demonstrated that GLP-1s will be very beneficial in the treatment of, for instance, something like knee arthritis. Nephrolithiasis was also observed. And interstitial nephritis were also observed in small numbers, and that has to be looked at. Pancreatitis has always been there, but again, it was in a very small number. But these are all of the observations that were made in this huge group of people. So only 40% of people stay 1 year after a GLP-1 receptor agonist was prescribed. Why is that? Well, first of all patients stop taking their medicine. We know that. They're too expensive, these drugs, and that makes many people stop. That's known. Some stop when the desired weight loss has been obtained, and then that creates all the problems of maintaining that weight. There may be the side effects that we discussed for 10-15% of the people. And then there is, of course, the loss of reward that we discussed, which may stop people from taking these drugs. But the most important is that in the period when you are up titrating, which can be up to half a year or more, then one should use the weight loss period for lifestyle changes. One should change diet and change exercise habits because that is very essential for the results. If you don't do that, there is a risk that you may lose lean body mass during the therapy. And here you can see that those that are able to exercise after the study and during the study will be able to maintain the weight loss much better than any other groups. So that is going to be very important. So change of lifestyle changes in diet, so that you can maintain your lean body mass, better vitamins and proteins, and also exercise. And it doesn't take a lot, and it will be easier because of the weight loss. So about the WHO recommendations of 30 minutes per day, and all it takes is brisk walking. So and that will be possible because you have a lower body weight and less joint pains and things like that. Just let me tell you, when you're about to choose, then this was a depiction of the effect of the various compounds here that was published in the Nature, and here you can see that they all are very effective. Some a little bit more than others. Here we have the retatrutide here, the winner. But actually, if you compare it to amycretin, the rate here is the same. Here you have tirzepatide here, of course, but if you compare it to semaglutide at 7.2, you also have the same. So there are choices here, and you can look at them. So the overall conclusion is that GLP-1 was discovered as an insulinotropic hormone that also inhibits glucagon secretion. We showed that. GLP-1 also inhibits food intake and appetite. It acts via the afferent neurons and the circumventricular organs to regulate appetite and reward. The GLP-1 receptor agonists are effective in obesity and diabetes. They have protective effects on the cardiovascular system and offer renal and neuro protection. They will change obesity and diabetes therapy, no doubt about that. So thank you very much for your attention. Thank you and goodbye.